Okay, good evening. This is a very special night because tonight we have Professor Amr El-Husseini Mohamed. He is one of the best friends that I ever know. Professor Amr is well known by his enthusiasm to do something, and I think he proved himself through his journey in the United States. Nowadays, all of us here in Egypt, we are proud that Professor Amr is full professor of medicine and nephrology at Kentucky University, and he is dedicated to many aspects. And I think he is specialized in the bone and the kidney. So today, his talk is renal osteodystrophy, and I think we'll need to hear from him many series. Inshallah, we'll start today by the current and the future perspectives. Professor Amr.
Thank you so much, my dear friend, Dr. Hassan Shaisha. I really appreciate your invitation to this webinar. And I'll try to be simple as much as possible because renal osteodystrophy is not a simple thing. It's a little bit complicated. And people understanding to this pathology is a little bit different. So I will stick to the common language and the well-known information, and I'll try to stay away from the controversies. So it will be very basic. Hopefully everybody can understand it and can enjoy this presentation. This will be depending mainly on a clinical scenario of a case. It's like a demo case, but I think all nephrologists are seeing this kind of complicated bone problems every day. And if you ask 100 of renal osteodystrophy specialists, they can give you different opinions. But we'll try to make it more sense and to prove that we can walk through this complicated path smoothly and swiftly. First of all, I think I have to say that I have some disclosure, but I don't get any money from any pharmaceutical companies, and I'm not going to talk at any of the bone therapies or interventions today. I'm not going to talk about any off-label usage. And even the multi-center trial that I'm involved with some of the pharmaceutical companies, they don't do anything with the bone. I have one of the phase 3 randomized clinical trials to evaluate efficacy and safety of avacopan, which is a C5a inhibitor in ANCA-associated vasculitis. And this is a multi-center study that's funded by ChemoCentrix pharmaceutical company. And I have also another multi-center trial, phase 3. We are studying the Nefecon as a potential therapy for IgA nephropathy. And this study is funded by the Calliditas. Again, nothing related to the bone here. So the objectives of this lecture is to understand the fundamental of renal osteodystrophy, the definition, the pathophysiology, and to understand the complex relationship between osteoporosis in CKD patient and renal osteodystrophy. And also we'll discuss the current and the potential diagnostics. So this presentation is not focusing on medications or the intervention, but it will be focusing on more about diagnostic. Then in the future, we can talk about the different intervention to treat renal osteodystrophy. So I want everybody to focus on this case. Again, we are going to walk through this case all over our presentation today. So this is a very common scenario we can see all the time in our dialysis unit. She's a 58-year-old female. She has end-stage kidney disease. She is on dialysis for the last 2 years. She had a fall in her bathroom, and she fractured her left hip. she had a surgery, and the surgery was successful. And she came back to our hemodialysis clinic for her regular 3 days a week dialysis. She is on calcium acetate and doxycalciferol, the Hectorol, vitamin D analog. And this is her lab, the most recent updated lab. Her calcium is 9.8, phosphorus 5.6. Her intact PTH level is 159, hemoglobin 10.4, albumin 3.2, alk-phos is 108. So what do you want to do next for this? I can say it's a daily problem that we are facing in our dialysis clinic and for our CKD patient who had history of fractures after minor trauma. So I'm going to discuss this case over and over, step by step, and walk you through the diagnostic and the approach and the algorithm. How can we reach the final diagnosis for this patient? Because the medication should be based on a solid evidence about her type of renal osteodystrophy. So what's renal osteodystrophy? Let's start very basic. So renal is, kidney, right? Osteo is bone, and dystrophy is a combination. It's a disorder characterized by abnormal development, weakness, and degeneration of the bone. You can say maybe abnormal development happen in little kids with rickets or osteodystrophy in children, but bone is very, very active organ. So bone development happen all the time. It doesn't happen only in children. Of course, it's more active in children, but also the osteoblast, the osteoclast, and the osteocytic function happens all the time. And bone resorption and bone formation happen all the time. So bone is in a state of continuous development through something called bone remodeling, which is combination of bone resorption and bone formation. So the key DIGO, the kidney disease improving global outcome organization defined renal osteodystrophy. Sometimes I'll be using the word or the abbreviation ROD, or renal osteodystrophy. And sometimes I will be using also CKD, which is chronic kidney disease, or CKD-MBD, chronic kidney disease, bone marrow disorder. So the ROD, the renal osteodystrophy, is defined as alteration in bone morphology in CKD patients. It's very, I would say, non-specific term, alteration in bone morphology. If you want to define, hypertension or diabetes, they'll give you exact number, mild, moderate, severe, whatever hypertension, they give you numbers, specific numbers. But here they just give a very generic definition, which is alternation of bone morphology. What is that? Do we need to have bone biopsy to diagnose renal osteodystrophy? Can we diagnose altered bone morphology by non-invasive methods? We are going to discuss this during this presentation. ROD, or renal osteodystrophy, is one of the measures of skeletal component of CKD-MBD. And we can quantify the abnormality by histomorphometric analysis by bone biopsy. This is what the key DIGO defined the renal osteodystrophy. We don't want to mix this up with the CKD-MBD, because CKD-MBD is a broader disorder. The bone abnormality is just one component, but also this include abnormal lab and cardiovascular calcification. So the renal osteodystrophy is just the skeletal component of the CKD-MBD. as I said, I'll be very simple, and I hate to show you this kind of complicated slides. And I'm not going to talk too much about pathophysiology because I know that many of us you don't want, we are clinicians, want to be focused on more clinical aspects. But to understand the background of this and how we diagnose and how we treat, we should just talk simply, about the pathology or pathophysiology of the disease. So it's basically what happened in renal osteodystrophy. It's imbalance between bone formation and bone resorption. So the majority of our CKD patients, they have either increased bone turnover, high turnover bone disease, or low turnover bone disease. High turnover bone disease is usually associated with increased bone resorption and also increased bone formation. But the increased bone resorption is much higher compared to the increased bone formation. On the other hand, they might have low turnover bone disease. It's usually associated with low bone formation and also low bone resorption. So what is the mechanism behind this? So as you know, FGF23 is a major phosphaturic hormone that increases very early in the CKD-MBD process. And the FGF23 try to maintain normal phosphate homeostasis, so try to excrete more phosphate in the urine to prevent hyperphosphatemia. But it also decrease activation of 25-dihydroxycholecalciferol to 1,25-dihydroxycholecalciferol. And this inactivation of the vitamin D will increase the BTH secretion and release and formation. So BTH goes up, and BTH will increase the pre-osteoblast accumulation, will increase bone resorption as it increase release or stimulate release of rank L from the osteoblast that goes to the osteoclast and increase bone resorption. But also BTH stimulate bone formation. Also, there is different mechanism that can lead to the high turnover bone disease in our CKD patient, mainly hypogonadism, like our patient here, and let's just call her, give her a name, Susan. So our Susan patient, she is 58-year-old. She is on dialysis. She is hypogonadal because probably she has post-menopausal osteoporosis as well. 58 on dialysis, definitely she doesn't have enough estrogen. Also, heparin is one of the main reasons, especially patients on hemodialysis who are getting heparin regularly during their dialysis treatments. Heparin itself increases bone resorption. Acidosis is a major determinant of our bone abnormalities. So metabolic acidosis actually increase bone resorption and inhibit bone formation. So it's very bad. So there is more bone loss and it's not associated with bone formation. Activin, that's an enzyme that comes out from the mainly osteocyte, also increase mainly the bone resorption and increase bone turnover, but also can decrease bone formation. Here are the reason for our patient to have low turnover bone disease. Many of them can happen spontaneously, but also our intervention to treat high turnover bone disease can end up by flipping the coin and changing the spectrum of ROD from high to low turnover bone disease, especially if we use a lot of cinacalcet, the calcium mimetics, calcitriol or vitamin D receptor analogs, bisphosphonates that can oversuppress the BTH and decrease bone resorption and bone formation. aluminum toxicity and aluminum deposition in the bone decrease bone formation. Iron overload decrease bone formation. Strontium decrease bone resorption. Inhibition of the Wnt signaling, which is very important in bone formation, because our patient with CKD, they have very high level of sclerostin level, and sclerostin inhibit the Wnt pathway and inhibit bone formation. Moreover, malnutrition inhibit bone formation. Our patient with on dialysis and late stage of CKD, they have lower level of IGF, insulin growth factors that decrease bone formation. So several, many factors. This is important because if you want to treat, you want to prevent this vicious circle, and you want to interfere before this happening. Early intervention is much better than late. So if we can control or prevent these molecules, cytokines, and the protein from going up and having a very high level and stimulating the bone resorption or decreasing bone formation, this will be very important. I like to have some interactive discussion. I don't want to just talk to one direction. So just a very simple question. What do you think is very, straightforward question? I'm not asking, any hard question. So what starts first in the process of CKD progression? Is it hyperphosphatemia, hypocalcemia, decrease the 125 vitamin D level, the 125 dihydroxycholecalciferol, which we call it calcitriol, increase BTH levels, or increase FGF23 levels?
So we have answers here from Dr. Mahmoud Sobh, from Dr. Salwa, from many interactors, and they are differing from FGF23 to phosphorus to calcium. So a lot of choices are there.
Okay, very good.
Okay.
So just think, I don't know if you guys have CKD clinic. Do you see CKD patient prior to dialysis? Just think, clinically, try to think, to be mentally oriented with the clinical stuff. So I have a CKD clinic. I don't usually see hyperphosphatemia in CKD stage 2 or 3 patient. Usually hyperphosphatemia is a late finding. And we just discussed this because FGF23 level prevent hyperphosphatemia. BTH also prevent hyperphosphatemia. So both BTH and FGF23 are phosphatoric hormones, so they are compensatory. The compensatory increase of BTH level and FGF23 levels prevent early onset hyperphosphatemia. So hyperphosphatemia usually happen late if the BTH and FGF23 fails to control this, because usually there is some kind of down regulation of the receptor and resistance of their action. Hypocalcemia. Do you usually see hypocalcemia even in our dialysis patient, advanced CKD stages? We don't usually see, especially if you correct the calcium, serum calcium level to the albumin, you don't see hypocalcemia. And decreased calcitriol level that happen a little bit early. BTH level goes up, but after inhibition of conversion of 25 to 125 dihydroxycholecalciferol. So the first initial things that happen usually in the process of the CKD-MBD is increased FGF23 levels. Here is a study that was done by Izakova. They published this 5 years ago. And in the spectrum of CKD-MBD, you can see the first biomarker that goes higher in the CKD-MBD is the FGF23. It starts in CKD stage 2, early CKD stage 2. Then the next one that goes lower is the vitamin D level. Vitamin D level, the 125 dihydroxycholecalciferol, which we call it calcitriol, usually start to go down in early CKD stage 3. BTH usually doesn't go up till stage 3B, which is GFR 45 or less. And for phosphorus retention doesn't usually happen till CKD stage 4 with eGFR less than 30. Okay, so let's talk a little bit about osteoporosis and the fractures. There is pathological fractures, there is low trauma fracture or atraumatic fracture, and there is traumatic fracture. Everybody can get traumatic fracture. If you have motor vehicle accident, if you have a fall, from 2 or 3 stories house or something, major trauma can cause a fracture to anybody. But what about low trauma or atraumatic fracture or non-osteoporotic fracture? It's very common problem. This studies, you just compared, people who had heart attacks, strokes, breast cancer. If you combine all of these common problems, still the fracture with low trauma is much more common. The incidence of fracture is much higher than all of these common problems. So fracture, we deal with fracture in every day. And fracture increase with the CKD progression. So patient with advanced CKDs, they have higher rate of fracture, and also they have higher rate of falls for different reasons. So they can fall and they can have a higher chance of fracture if they fall. And they fall because of different reasons, Many of them, especially dialysis patients, after dialysis, they are a little bit dizzy or lightheaded, they have some orthostasis. They have myopathy, they have muscle weakness, so they can fall, they have autonomic neuropathy, they have neuromuscular problem on top of the skeletal problem, and they have also a cognitive problem. Here is the prevalence of fracture in our dialysis patient. In different studies, is a meta-analysis, and you can see from 10% to 52% of our dialysis patient experience fracture in the past. This depends mainly on the duration of the dialysis and duration of CKD, and also the age of the patient. So patients who are, on long dialysis and they are elderly, you can see 40–50% of those has fracture. I want you to focus here the spine fracture. Spine fracture is very prevalent in our end-stage kidney disease. In different studies, they tell you from 30 up to 33%, 25%, 28% of our dialysis patient has spine fractures. The major problem with these spine fractures that this can happen unnoticed. The patient doesn't, it's not like hip fracture. The patient can have spine fracture and can have just chronic vertebral pain or back pain. And if you don't diagnose it, you don't see it common or prevalent in your patient. So we have to be more vigilant how to diagnose this spine fracture. And this spine fracture can affect our patient quality of life. And here is an example. There is the thoracic vertebrae number 7, the T7 fracture. And you see, instead of this patient had in the past straight vertebrae, straight spinal cord, now he is very kyphotic. He cannot walk and he will end up by chronic back pain. The problem with renal osteodystrophy and osteoporosis, it's bidirectional. This means that you cannot be healthy and ambulate and active without having healthy bone. And at the same time, also, you cannot ambulate or being active without having healthy bone, and you cannot have healthy bone without being active. So being active gives you more chance for sun exposure, for your osteocyte and osteoblast and osteoclast better function and better bone health. The consequences of fractures, especially in our dialysis patient and CKD patients, are huge. Patient who has already history of atraumatic fracture or low trauma fracture have very high chance of having more fractures in the future. These patients, they go to the hospital, so they are hospitalized, and after long hospitalization, they go to a rehab to get their strength back. They end up by having chronic pain, they take pain medications, and this pain medication has a lot of side effects, and they can make them dizzy and increase the risk of fracture. The quality of life changed dramatically in this patient. After the patient was independent, now he depends on others for movements. He cannot walk. So the patient before the fracture, he can be a productive person in his community. Usually after fracture, his whole life changed. And this has a lot of consequences on not only on the health care, but also on our social life and economic consequences. Death is very high. Our patient who had a hip fracture on dialysis, they have 30% of them or more, they don't live for a year. So more than 30% of our dialysis patients who experience hip fracture, they die. And the mortality rate in 2 years is about 50% or higher. Okay, so back to our patient. I just want you to focus on this patient, which is a common patient and common problem that we are facing. This is a 58-year-old female on dialysis who had low trauma fracture, and she had successful surgery, and she's taking calcium acetate and some doxycalciferol, and this is her lab. She has mild hyperphosphatemia. Her calcium looks okay, BTH 159, hemoglobin 10.4, albumin 3.2 after this prolonged hospitalization. So, and the nutritional deficiency. Alk phos is 108. What do you want to do next for this patient? Do you want to do nothing because her lab looks good and the fracture was fixed? Or you would like to increase her calcium acetate or increase her dialysate calcium, or order a DEXA scan, or increase her vitamin D receptor agonist, increase her doxycalciferol. What do you think? Any taker?
So the majority of answers are focusing on DEXA scan, but there is an answer to stop calcium and vitamin D first. And the majority
there is
takes
no,
DEXA.
there's the choices is increase calcium acetate, increase dialysate calcium. So the majority choose
DEXA.
to order DEXA scan.
Yes.
Okay.
But there is also reduction, stopping calcium and vitamin D.
Okay.
No.
Okay.
Okay.
So do you want anybody who can explain why do we need to do a DEXA scan to this patient?
So Dr. Mu'tasim, we can ask any of the audience who selected to just raise your hand and start to the dialogue with us, please.
So what does DEXA scan add to this patient who already have a fracture? And this fracture is atraumatic fracture or low trauma fracture.
Dr. Mahmoud Sobh, you can start the dialogue.
What do you What do you think, Mahmoud? Why do you want to order DEXA? What does DEXA add to this patient?
I think they may be a little increased risk for osteoporosis. It's evident by fracture, yes, but maybe comparing searching for a secondary cause for osteoporosis.
Thank you, Mahmoud.
Secondary cause of osteoporosis. What is the secondary cause of osteoporosis here?
Can we take another interaction from Dr. Mohamed Mamdouh?
It's a very good answer, by the way.
Mohamed Mamdouh?
Yes, Assalamu alaikum.
It's okay.
Alaikum salam.
Alaikum salam.
Mamdouh should know this answer. He's working with me on different kind of research.
Okay. Okay, so I will skip.
This is why I invited him to answer.
Very good.
Okay, Mahmoud, تفضل.
What do you think?
Okay, Mohammed.
I will skip.
Mohammed.
Okay.
Mohammed, continue, please. Mohammed Mamdouh.
I think that bone biopsy would be the best choice for the patient because we don't know if the patient is dynamic or adynamic. We already know that the patient is osteoporotic, but just as this, we know that the patient has osteoporosis, but what is going on the bone, we don't know, I think. So if we can do, I think renal biopsy, bone biopsy, it would be better.
But bone biopsy is not an option here. Do you see the screen? Do you see the 5
Yes,
options
it is
I give
not an
you?
option.
What option do you choose?
I think in this option, I don't know.
Okay, good. So let us just stick to our key DIGO guidelines, what to do with this kind of patient. So when it comes to diagnostic for the bone, they said in the 2017, there was 180 degrees change in their recommendation regarding the bone diagnostics, especially with the BMD, was using DEXA scan. So the KDIGO recommendation, the 2070 recommendations, they said in CKD patient with stage 3A to 5, including dialysis, who have evidence of CKD-MBD or risk of fractures for osteoporosis, they recommend to do DEXA BMD testing to assess the fracture risk. And we'll talk about this fracture risk. How can DEXA help us to assess the fracture risk? And they said, this is conditional. They said, if results will impact treatment decision. So before ordering DEXA to our patient with CKD, who has evidence of CKD-MBD and or has a risk factor for osteoporosis, we have to discuss if this will impact the treatment decision. That's a very important statement. Okay? And we know that what is the risk factor for osteoporosis? The risk factor for osteoporosis is, we have many factors, but postmenopausal osteoporosis is very common because of estrogen deficiency. Patients who are smokers, patients with sedentary life who don't exercise, and the majority of patients, they don't exercise, they are not very active. Patients who had a history of corticosteroid usage, and alcohol. I don't think we have this problem in each. Okay, so why did they change? By the way, they changed this from 2009 to 2017 radically. So in 2009, they said they voted against and they recommend against to use DEXA scan and testing the BMD because they said it doesn't predict the fracture. But they changed that in 2017 because of multiple new prospective studies. There was mainly 3 big studies that showed that DEXA scan predict fracture risk in our CKD patient and dialysis patient. I'm not going to talk about the biopsy right now. We'll leave it till the end. But they said, instead of having a specific indication for the biopsy in 2009, they just moved this to a simple statement. They said, you can do bone biopsy if knowledge of the type of renal osteodystrophy will impact the treatment decision. So again, they tried to be more practical. So if you think that bone biopsy will add or will help in approaching and treatment decision, yes, you can do it. Okay, so we ordered DEXA scan for this nice patient. I think we call her Susan, right? So Susan had a DEXA scan, and here is her DEXA scan result. Does anybody want to comment on her DEXA scan result?
Anyone wants to comment, please raise your hand and we can start the dialogue. Dr. Mu'tasim.
Yes, Dr. Hussein.
Yes, what's your comment about this?
Can you see Mu'tasim? Can you see this DEXA scan result?
Yeah, yes.
Okay, so can you comment?
Osteopenia, 1.4 T-score. Total T-score is 1.4.
Is this good or bad?
It's not osteoporosis. I think it's little. It's bad, of course, but it's little. It's not much bad as having osteoporosis.
Okay. Any other speakers? Mamdouh, what do you think about this T-score? 1.4 of T-score. And by the way, you can look also for her BMD at different sites from the arm, the distal radius, the ribs, the spine, lumbar 1 to lumbar 4 spines, and also the hip. So,
Dr. Hani Mansour. Hani Mansour, please. Dr. Hani from Saudi Arabia.
Hani, what do you think?
He wrote already. It is not bad because if this score is is positive, it is good.
Okay, very good. So let's keep going. So does this patient have osteoporosis? This is my question for you guys. Depending on this, and I have the DEXA scan result here again for you. So the first choice is no, she doesn't, because she has normal BMD at all points and normal T-scores. Second option, maybe as her Z-scores may be less than 2.5. The third option is maybe she has osteoporosis, as normal BMD doesn't exclude osteoporosis. And the last option is no, she only has osteopenia. So does anyone want to discuss these options and choose the best option?
Dr. Ahmed Boja, he selected already choice D. If he can,
which is no, she only has osteopenia. Okay.
Okay.
Okay, Dr. Ahmed.
Hello?
Yes.
I think it has only osteopenia because the T-score in most of the bones not less than between 1.5 to not less than 2.5.
But to say osteopenia, we need -1 to -2.5. And here everything is positive. So
the total score is 1.4.
It's positive. It's positive. This means it's normal.
Right.
I think it is only osteopenia.
Osteopenia is between -2.5 to -1, so all are negative. Osteoporosis, it's worse than -2.5. And if the patient has anything more, higher than -1, T-scores, this means that the BMD is normal.
Dr. Gada selected maybe as her Z score, maybe minus 2.5 lower.
Which Ghada?
Dr. Gada, Gada Subhi.
Does she want to interact and tell us why she chose this option?
Dr. Gada
Or does
Subhi.
anybody want to discuss his choice? Why did he, choose any of these options?
So I think it's better to go ahead because it's very
Okay.
interesting. This is very interesting for me. T score is
Okay.
normal.
So,
T score
okay.
and there is fracture.
Right.
Okay.
Okay. So let us discuss one by one. The first option, no, she doesn't have osteoporosis. She has normal BMD at all points. So this comes to a question, does normal BMD, if you have normal BMD, does this exclude osteoporosis? And definitely the answer is not. By definition, this patient have osteoporosis. If you have fragility fracture, this means that you are osteoporotic. So osteoporosis is not only BMD and not only using T-scores or Z-score or whatever score you are using. Osteoporosis, we'll come to this in the next, here in the next slide with the definition. So definition of what is the definition of osteoporosis is mainly two definitions, one by NIH and one is by WHO. The NIH, about 20 years ago, they said they define osteoporosis as a skeletal disorder characterized by compromised bone strength. So it's a problem with the bone strength, but it's posing to increase risk of fracture. And they said bone strength primarily reflects integration of bone density and bone quality. That's very interesting definition. So osteoporosis is not only low BMD, it's not only T-scores of less than 2.5. Osteoporosis is compromised bone strength that increase the risk of fracture and doesn't only reflect bone quantity or density, but also bone quality. So the first option here is out. Okay, let's discuss second option. Maybe as her Z-scores, maybe less than 2.5 or lower. So to discuss this, we have to understand what is the difference between the Z-scores and the T-scores. So basically, T-scores compare the BMD of the patient, this lady, with a group of people who are healthy in their age between 25 to 30 of the same gender. So they are going to compare to get a T-score for this lady. The computer system already stored many of the normal values for people who are healthy between age of 25 to 30 of the same gender. So they are female, for example, for this lady. Z-score, and this is, it's a philosophical discussion. If you have an 80-year-old female, do you want her bone to be as healthy as 20 or 25 or 30-year-old healthy person? Of course, this is unfair comparison. Why do you want to compare an 80 or 90-year-old bone to a 30 or 25-year-old bone? But again, on the other hand, if you
Dr. Amr.
the peak bone volume by that age, 25.
Excuse me, Amr. Excuse me. Can you please repeat the sentence because we lost your voice for a second.
Same age.
Okay.
Mm-hmm.
So again, the last statement, please. Amr.
Mhm.
Okay, please again repeat this slide, please. We don't have your voice, Amr.
Guys, do you hear me?
Yes, now yes.
Yes, we hear you, Dr. Amr.
Again, Amr.
T-score is different from Z-score because Z-score compare the BMD with people of the same age. So they compare this 58-year-old female with people who have around her same age. So for elderly people, usually the Z-scores are lower than the T-scores. Do you understand? Because we compare it with people of the same age, higher age, or and we expect that this patient at her age or higher age will have lower BMD. So the Z-score.
Excuse me, Dr. Amr. Would you please repeat the difference between T and Z score?
So the T-score in the DEXA machine, they store a lot of normal BMDs, and normal BMDs usually happen for people who are 25 to 30 years of age. By that time, we reach our peak bone volume. You start to build up more bone, and you reach this point, then after the age of 30, you start to lose bone. So the peak bone volume happen around 25 to 30 years of age. So the T-score compare if you are 80-year-old and having a DEXA scan, the T-score compare your BMD to a 25 or 30-year-old healthy person. The Z-score compare it to people who are, around your age. So if you're 80s, you compare it with, elderly people. So usually in elderly people, the Z-score will be better than the T-score, right? So there is no way for this lady who is 58-year-old, she's not old, but I mean, she is above 30. There is no way for her T-scores to be lower than for her Z-score to be lower than T-score. Usually her T-score, if her T-score is 1.4, her Z-score should be higher than that, okay? And we don't usually use Z-scores for this kind of people. We usually use Z-scores for children, not for elderly people. Okay, let us. Is this clear, Hussein?
Yes, Dr. Amr.
Okay.
So Z score is used in children or elderly?
Mainly in children, right? T-score is more popular.
So what is the value of Z score? From the
here again, it's a philosophical discussion. Do we need to use Z scores or T scores?
Because I just remember from the old readings that Z score give us idea about hyperdynamic or lower dynamic osteoporosis. Is it right or wrong?
So it depends. Again, usually the DEXA scan will give you the two readings, and you can choose which one you want to use. And again, it's a philosophical discussion. If you want to compare your patient to her, the people who are around her age, use the Z-score. There is no problem with that, which will be much better for elderly people. If you want to compare her with very healthy people with very normal BMD and people who has their, at their peak bone volume, use the T-score. Again, it's like, blood pressure. Do you think an 80-year-old guy should have a blood pressure as a 20 or 25-year-old guy? The normal values, are they both the same? Ejection fraction for the heart, for example, showed an 80-year-old guy has the same ejection fraction as a 20 or 25-year-old healthy person. EGFR for our patient, same example. Do you think an 80-year-old guy should have the same EGFR as a 20-year-old guy? So it's philosophical discussion, but they usually give you both reading and you can choose which one you want to use. Okay?
Okay, Prof.
Okay, let's discuss the third option. Maybe this patient has osteoporosis, as normal BMD doesn't exclude osteoporosis. And this is, by the way, the right answer. And I'm going to explain to you why. The fourth one is definitely wrong, because no, she only has osteopenia, and we discussed she doesn't have osteopenia depending on this number, because her BMD is positive, not negative. Then we discussed this, the definition of osteoporosis by NIH, which is a compromised bone health that include bone density and bone quality. So this is another definition. If you want to use the WHO definition, which is an older definition, was made 1993. It's a skeletal disorder characterized not only by low bone mass that can you detect and evaluate by DEXA scan, but also by microarchitecture deterioration of the bone that leads to fracture. By the end of the day, you are going to assess the bone strength and predict the risk of fracture. This is a major thing. Fracture for the bone is like, heart attack. When the patient have hypercholesterolemia, hypertension, then they end up by heart attack. Also, fracture is a bone attack. So patient will have weaker bone, the strength of the bone will be bad, then they will end up by having a fracture, which is a bone attack. So we would like to prevent this attack. You don't do it, wait for a patient to get heart attack. There is primary prevention, secondary prevention, and tertiary prevention. You control their blood pressure, their blood sugar, their cholesterol, they are overweight, you try to reduce their overweight, and they are a smoker, you try to stop. Same thing here for the bone. We want to have normal bone health, so we want to avoid rather than interact late after the patient will have lower bone mass and bad architecture. If you go with the WHO classification of osteoporosis, just depending on BMD with T-score less than 2.5, you should know that the majority of fracture happen to patients with no osteoporosis. We call it non-osteoporotic fracture, okay? More than 60% of women with fragility fracture or atraumatic fracture or low trauma fracture, they have non-osteoporotic BMD. Either they have osteopenia or they have, like our patient here on dialysis, they have normal BMD. And as you see, of course, the fracture risk goes up in patients with lower, BMD T-scores. But at the other hand, you see here is a 2.5. So here is a fracture that happen in osteoporotic patients. But the majority of fracture, more than 50% of fracture, happen to non-osteoporotic patients if you classify osteoporosis depending on low BMD was less than 2.5 T-scores. Let us focus, we need to focus on our bone. Is it healthy? Is it strong? And all the time we get this question, is my bone healthy? Is my bone strong? How can we check and evaluate the bone strength and the bone structure? I will make it very simple. This lady is trying to check the height of her husband. So she stood on this seat or stool, and she can have a fracture. She can have a fall and fracture. Her fracture risk will increase if this stool is weak. How can we check if this stool is strong or weak? Bone is a structure. As analogy, think about bone as a seat or chair. This one is made of steel. So this one is more denser than the wood. This one is lighter, this one is heavier. So if both have the same structure, same hinges, connections in between, macro and micro structure, you would choose the denser seat because of the material, because it's more dense, because it's steel. What about if we take out the connections, the hinges and hinge between the legs of this seat? What will happen? Probably this one, the wood one, because it has a better microstructure and better strength, it can stand, our setting without problem. So this one, instead of it's made of steel and it's denser, it will be weaker. You can not depend on this because the structure. So exactly this is what happened with DEXA scan. DEXA scan checks only the density of the structure, but it doesn't check the other bone quality parameters. So to have a good bone, you need good density and also good structure. And this structure, it depends on macro structure, microstructure, and nanostructure. So there's different level to check on this structure. So bone strength is not only bone density. The DEXA scan that we are using when we use the BMD or the T-score and Z-score, depending on our hip and vertebral and radius BMD, gives us only one information, which is the bone density. Okay, it doesn't give us any information about bone turnover, high or little or low bone turnover. It doesn't give you information about bone architecture, and it doesn't give you any information about the composition of this bone, because the bone is composed mainly of two elements. One is organic and one is inorganic. The matrix is a protein, a collagen, which is the organic component of the bone. And the minerals, calcium, phosphate, and apatites, they are the inorganic components. So it mainly, if it gives you any, it gives you information about the minerals and the mineral bone content, but it doesn't give you any information about the matrix, the protein, the collagen, and the architecture and structure and bone turnover. Is it more important to check and to evaluate our bone quantity or our bone quality? So again, it depends on how you read it. You can read the first sentence here as opportunity is nowhere, and you can read it that opportunity is now here. So depending on what you want to read and what you want to focus on. These guys, are many healthy students want to pull the rope from this big guy. So they have more quantity, but this guy has more quality. So he is stronger. So it's always a battle between the quantity or the quality. You remember when we were little kids, they used to teach us that this guy, before he died, his father or grandfather, he collected his children and want to give them a lesson and give everybody a stick and ask everybody to break the stick, and they were able to do it. But when he gave them all the stick together, everyone wasn't able to break the whole sticks. So they were teaching us about the unity. How can we stand, up together? But what about the quality? Is it different if this bone is very strong? I think if this, structure, this stick or whatever is made of very strong, structure with good quality, whatever the quantity they have, whatever unity they have, they cannot break the good structure. So again, quantity or quality. Let's go back to our BMD. So BMD or DEXA scan check the bone density. And bone density is only about 60% of the bone strength. But what about bone quality? What about the matrix, the collagen quality, mineralization rate, bone size, bone shape, and microarchitecture? This bone quality gives you about 40% of the strength of your bone. So DEXA scan, of course, it's very popular, it's relatively cheap, and they give you the result of your DEXA scan very quick. And it's very informative, very simple. They explain it to you, and you will be happy when you do the DEXA scan. It's non-invasive procedure, low dose radiation. Usually it takes 10, 15 minutes, 20 minutes at large. And it correlates in many studies, the BMD and T-scores correlate with the cortical porosity in the histomorphometric analysis in dialysis patients. So it's very widely used technique and was, studied very intensively in the past. But the problem of the DEXA scan, it has a lot of limitations, especially in CKD and dialysis patients. It's only an areal density measurement. It doesn't measure the volume. You remember the BMD is gram of minerals per centimeter square. So it's not volumetric. So to check the volume of the bone, you need to do a CT scan, with a QCT scan to check on the volume. Instead of measuring the gram per centimeter square, it will assess the volumetric nature. It will be gram by cubic centimeter, not by square centimeter because of volume. Also, the DEXA scan cannot differentiate between cortical and trabecular. Remember, we have two kinds of bone, and especially in dialysis patient and advanced CKD patient, we have a problem in both trabecular, which is the inside layer, the spongy layer, the cancellous layer of the bone, and it's mainly in the vertebrae. And also we have a problem in the cortical bone, which are mainly in the femoral, femur neck, and long bones, and it's the outer layer, compact layer of the bone. Also, DEXA scan does not measure bone size, which is another problem. And it gives you false positive results, especially in our patient. Like this patient with BMD of 1.4, this can be a false positive test because many reasons, but one of the major reasons in the dialysis patient is because they have cardiovascular calcification, and this cardiovascular calcification in the aorta can give you false higher readings for the BMD, especially when you are checking the vertebral BMD. Also, if they have fractures or osteophytes, they can give you different readings. DEXA scan doesn't predict the type of ROD, so it doesn't predict high turnover or low turnover or osteomalacia or this kind of stuff. But the major advantage of DEXA scan is it's included in the FRAX tool to assess the fracture risk in general for the general population. So you can use this FRAX score to calculate the risk of fracture within 10 years for your patient, depending on the age, race, weight, height, and the BMD with other reason for loss of bone, like smoking, corticosteroids, secondary osteoporosis. By the way, secondary osteoporosis here, they don't include the kidney disease as a reason for secondary osteoporosis, and this is a major limitation in our patient. Okay, let's go back to our patient. So she has normal BMD. Does she have a bone quality problem? Of course, as we discussed, BMD, normal BMD doesn't mean that she has a normal quality. It could be a normal quantity, normal density, but not quality. How can we evaluate her bone quality? There is different. Yes, sir.
Dr. Amr,
Yes, Hussein. Yes.
would you please answer my question regarding the point of DEXA scan? Before 2017, all of us were suspicious about the use of DEXA scan and its validity in CKD and dialysis. So long as today you presented this false results of DEXA scan, why in the 2017 they opened the door for the value of DEXA scan? Is it because
Right.
the feasibility and availability of DEXA scan?
It was because there were three big studies, prospective studies that showed that despite of all these limitations, it still can predict fracture risk and CKD patient. It doesn't mean that it's 100% accurate. It has its own limitation. But as we discussed here, there is a lot of advantage. This might be, it's very popular not only in CKD patient, but also in all patients to assess. It's the most widely available technique to assess bone health, but it doesn't give you 100% information about your bone strength. It gives you assessment mainly on bone quantity, not bone quality. And as we discussed, there is false positive, especially in advanced CKD. Maybe in early CKD, it predicts better, but in advanced CKD, patient on dialysis for a long time with a lot of cardiovascular calcification, the prediction of fracture and the reliability of this test will be lower. But again, it's a good test. I don't want to say it's a bad test, but it has its own limitation. Nothing is 100% perfect. Am I clear?
Clear, Basha.
Thank you. Okay, so how can we assess the bone quality? So we said the DEXA scan, the BMD, especially if we just use the BMD to assess our bone health, it doesn't give you quantitative assessment of the bone. It gives you just quantitative, not qualitative assessment of the bone. Now, they added another technique to check on the bone quality in our patient, which we call it TBS, or trabecular bone score. So please remember this. I don't want to go through the details of this, but if you remember T and Z score, if you remember BMD for DEXA scan, remember also that you can use DEXA scan using the same machine with no extra time. It's just a software that they introduced, and it's more popular now. Here we use it in all of our patients. We add this software to all of our machines to assess the TBS, or trabecular bone score. They give you a score for your trabeculae in the vertebrae. So it gives you some information about the structure and microarchitecture and bone quality in the vertebrae. Very easy to use, and I will show it to you in a second. Other ways to check on bone quality, there is quantitative, CT, and also this is, volumetric assessment rather than aerial assessment of the bone. And also there is something called high resolution peripheral quantitative CT. It's called HRBQ-CT. It's done on the radius and can give you more information about your, quantitative assessment of your bone. And now there is also micro MRIs and even PET scan that can give you an information about the microarchitecture. Of course, the gold standard is the invasive bone biopsy, but all of these information you can get not only to depend on one element for assessment of the bone, which is the BMD, and depend all of your decision to treat your patient depend on BMD, but also you can get more information if you want to check by checking these studies. Okay, here is trabecular bone score, TBS. How does TBS help you in general to predict the risk? See, this group of patients, group A, they have osteoporosis and they have low TBS, low therapeutic bone scores. So of course, this group of patient group A has the highest risk for bone fracture. On the other hand, this group of patient group B, who has normal BMD, so no osteoporosis, no osteopenia, they have normal BMD, and at the same time, they have normal TBS scores, they have the lowest risk of fracture. Okay, let us compare C and D. C are patients with osteoporosis by BMD, but they have good TBS. Okay, D, they have the opposite. They have bad TBS, therapeutic bone score, but they have good, BMD with a T score. So if you compare those, so you can see patients still have osteoporosis, but have lower fracture risk compared to this group of patients who have lower BMD, but higher TBS. So using both scores, not only the BMD, but also the TBS, will give you information not only about bone quantity, but also bone quality, and you can get more predictive power for the fracture in the future. This doesn't only help you to predict the fracture in the future, but also it can help you to decide the treatment modality. If you are giving VTH to increase bone formation, the Forteo, for example, Forteo increased, and this is a 2 years study, increased the BMD about 10% and increased the quality of the TBS about 6%, 5% or so. If you are giving denosumab, for example, denosumab mainly improve the bone quantity, so increase about 8% in the BMD, but only less than 3% improvement in the bone quality. Bisphosphonates doesn't help, to improve your bone quality. It helps on bone quantity, about 5% increase in BMD and 24 months, in 2 years. Using hormonal replacement therapy might be helpful to improve your bone density, but it's not helpful at all to improve your bone quality. These are the placebo group. They, of course, lost a little bit of their BMD and TBS, so bone quantity and bone quality. These are patients who received corticosteroids. There is mainly corticosteroids affects the bone quality. It doesn't affect the bone quantity much. So if you repeat the BMD, you see the BMD is not going down very much, but the TBS will go down. And these patients are taking anti-aromatase therapy for the cancer. They mainly lose the quantity. So it's important to know that it doesn't only help you in a prediction of fracture, but also the management and how does your medication affect your bone strength. Okay, let's go back
Dr.
for
Amr,
some
Dr.
Yes,
Amr,
sir.
do you have a score for trabecular bone?
Yes, it's coming. It's coming.
Okay.
So let's go back to our patient here. So just to remind you, 58-year-old patient on dialysis who had a traumatic fracture, and she had successful surgery, and this was her medication, and this was her lab data and her BMD. Okay, here is a TBS. So Hussein is usually ahead of time. He is very smart. So here is a TBS. So TBS, as you see here, anything in green is normal, anything in red is abnormal, and here is the yellow in between. So here is the in between, in the yellow range, and here is the good, here is the bad. So here, TBS was 1.1. The normal is between 1.2 to 1.4. Anything above 1.4 is good. Anything lower than 1.2 is bad. And hers was 1.1. So despite that, she had normal BMD with a T-score of 1.4. She had abnormal TBS, so she had probably abnormal bone quality, despite that she had normal bone quantity and normal BMD. So what do you want to do next for this patient? And let's do some interactive discussion here, because I hate to talk too much and I get tired. So I want you guys to help me to choose the next step for this patient. So this patient has bone quality problem rather than bone quantity problem. She has normal BMD and she has low TBS. Do you want to start bisphosphonates? Do you want to do further testing? Do you want to increase her calcium acetate, or start her on calcium mimetics, or increase her Hectorol, the VDREs, the vitamin D receptor agonist? What do you think?
So we have two answers. She needs further testing, and another one, her lab again, please.
Her lab again here.
Okay.
This is her lab. Mild hyperphosphatemia, normal serum calcium, or if you correct it, she will have a little bit calcium on the higher side because her albumin is low, 3.2, so it would be 10 point something. IBTH 159, alkaline phosphatase is 108.
Okay. So we have answers here. Give BTH, give bisphosphonate. And Dr. Amr El-Husseini raised his hand. Dr. Matasim, please help her just to share in the discussion. Dr. Amr.
ايوه دكتور حسين.
اتفضل.
لا انا معلش انا جيت بالغلط يعني، بس انا كنت عايزه اكتب بايفوسفونات مش اكتر.
Okay, thank you. Thank you.
Why did you choose Dr. Amr? Why did you choose bisphosphonates?
Why bisphosphonate, Dr. Amr?
Bisphosphonate.
Why?
Dr. Amr Zalouk. Because according to the graph, biphosphonate increase the quality, not the quantity. And according to the patient, she has a problem in the trabeculation. So I think it will help her.
So here is the bisphosphonates, right?
Yeah.
Bisphosphonates actually improve the quantity rather than the quality.
The quality,
here.
yes.
Yes. Here her BMD, right? So it improved about 5% in 2 years of the BMD, but it doesn't affect the bone quality much. Okay? The vertical axis here is the bone quality.
Okay.
The horizontal is the bone quantity. So you see here, it will improve her bone quantity, her BMD, about 5%, but it doesn't improve too much her bone quality. Would this change your mind?
Sure.
Maybe.
Okay. Okay. So
Dr. Mahmoud Sobh.
Mahmoud, what do you think?
I think before taking any decision, we need to see the trend, not only one shot for the lab.
That's very good. That's a very good answer. So I would say her lab was very stable at this range to make your life harder. What do you think? So if she has mild hyperphosphatemia, calcium is a little bit on the higher side, BTH 159, alkaline phosphatase 108, and she has this bone quality rather than bone quantity problem. What do you want to do for her?
Dr. Khalid Al-Khalidi.
Biopsy.
So you want to do further testing?
Bone biopsy, yes.
How can bone biopsy help you in this regard?
If it appears to be a dynamic bone disease, I may I think it might explain.
If she has a dynamic bone disease by bone biopsy, how would this change your treatment decision?
Dr. Khalid Al-Khalidi. Dr. Khalid. Okay, Dr. Amr, here
Okay.
another question about the use of bisphosphonate in dialysis. It was forbidden before 2017 or something, and if GFR is less than 30, it was contraindicated. But I think the 2017 guidelines opened the room for the use of bisphosphonate under a strict algorithm, and I think this will be discussed thoroughly in the next presentation when we ask you to give us another presentation about treatment and management.
I agree 100%. Bisphosphonate is very dynamic now. We use it if we have good evidence that the patient has high turnover bone disease, high bone resorption. So we can suppress this with bisphosphonates. But at the other side, if you give it for long period of time and you don't have a good evidence that this patient has high turnover bone disease, it can kill the bone and can change the spectrum from high get to a patient who already have a low turnover bone disease. It's a disaster. So you have to be careful. It's not contraindicated, still off-label use, but it has to be given with caution. And we have to follow other things to make sure that the bone is not going to die. And I'm going to explain this a little bit in the next 10, 20 minutes.
Okay.
But I agree with you, yes.
Dr. Khalid?
Okay.
Okay, we can go ahead, Dr. Amr.
Okay, so start bisphosphonates. I don't think we need to start bisphosphonates because we don't have good evidence in this patient that this patient has high turnover bone disease. Do you agree with me?
Yeah, I agree, yes.
If we are 100% or at least 90-something% sure this the bone resorption here is high, the osteoclast function is high, we can suppress that by giving bisphosphonates. You remember, bisphosphonates is not a day treatment or a week treatment. You give it for a year or two to see a response, right? It's an expensive medicine and it's not free of side effects. So you have to be careful while giving such kind of medication. Okay, let's discuss the second option. She needs further testing, okay? But if you choose this, you have to explain to me what further testing you need to do, right? I agree that I am not 100% certain what does this patient have so far. I am 100% certain that she has poor bone strength. Her bone is weak. But why does she have this weak bone? I'm not very sure. Probably she has problem in bone quality rather than bone quantity. But how to treat this patient, I'm not very sure yet. So I need further testing, and we'll discuss this option in a little bit. Increased calcium acetate is the worst thing to do for this patient because she already have mild hypercalcemia. Even serum calcium level doesn't reflect the calcium balance. So probably she has very good calcium balance. She is on a positive calcium balance. You remember she have normal, very good BMD with poor TBS, so she might have, some evidence of cardiovascular calcification that gives us higher reading for her BMD. This is possible too. So no, I mean, if she has low turnover bone disease or adynamic bone disease, and if you give her more calcium, this is not good because the bone is not very active. It doesn't utilize this calcium, and the calcium doesn't stay in the blood, and it has to go to somewhere else. And usually it goes to the cardiovascular system and cause cardiovascular calcification. You would like to start sinacalcet. Her BTH is just 158, and alkaline phos is 108. So she doesn't look like, she has high turnover bone disease, or her BTH is very high. So I don't usually start sinacalcet for this kind of patient. You'd like to increase her VDRAs, a vitamin D receptor agonist. She is already on it. A vitamin D receptor agonist probably will increase her phosphorus, will increase her calcium balance. And if she has low or adynamic bone disease, also this would be bad for her. So I would choose to do further testing, but the question is what kind of testing we need to do. So I would just discuss two further testing. There is bone turnover marker. It's serum marker in dialysis patient, urinary and serum marker for CKD patient before dialysis. There are several of them, and they can tell you some information about the bone formation and the bone resorption. You remember, you would like to give treatment either to decrease bone resorption or to increase bone formation. So if you have a marker that can tell you that this patient has a problem with a low bone formation, you would like to give medicine to improve bone formation. And on the other hand, if you have a marker that can tells you that this patient probably have high bone resorption, you would like to give anti-resorptive agents, okay? So there is several of them, but I just want you to focus for CKD patient, especially CKD stage 4 or 5. We usually focus on using the bone-specific alkaline phosphatase and the taritarate-resistant acid phosphatase. Very easy. You don't have to check osteocalcin. We usually check osteocalcin, B1NB, the CTX, NTX for patient with osteoporosis, not with the CKD. But when it comes to CKD patient, usually osteocalcin, the B1NB, the CTX are retained in our patients, so we don't use this biomarker, but we use TRAB5B as a biomarker of bone resorption, and the BSAB, the bone-specific alkaline phosphatase, as a marker of bone formation. They are not cleared by the kidney, and they are very useful biomarker, serum biomarker. You can use if you don't have availability to do a bone biopsy to be certain what kind of renal osteodystrophy this patient have. You still can use this non-invasive test. It's not very expensive, and I think you should have it in the Middle East, in Egypt, and the other countries.
And this is a question here, Dr. Amr. Are they available? And I'm not sure if they are available in Egypt.
I'm not sure either.
We have Dr. Magdi Sharqawi with us, and I think he has idea if these tests are available, Dr. Magdi, or not.
أنا معاك وافتح لي بس الميوت.
Okay.
Yeah, you are unmuted, sir.
How are you, Dr. Amr?
I'm very good. Missing you, my friend.
We miss you very much. Please stay safe.
I'm trying to.
Okay. Are they these tests are available here in Egypt?
Only for academic purpose. They are not common in the lab. But you can order them if you want, but they are not in common practice at all.
Absolutely.
Okay.
You remember, bone-specific alkaline phosphatase is just an isoenzyme from the total alkaline phosphatase. Okay?
I know. Yes.
So I think if we try to order this more often, there will be more labs, you have more kits, and you will buy it and you will make it happen. So it depends. I mean, it's, in Egypt, everything, I mean, it's commercial. Most of the labs are commercial. It depends on the need. If we need it, if we order it more, probably even if it's not available right now, they'll buy it because they start to make more money out of it.
That's why I asked Dr. Magdi, because Professor Sharqawi had a good experience and research in the bone field.
Dr. Hussein, we came into conclusion that if you are using just the alkaline phosphatase, the ordinary alkaline phosphatase, it can provide the same result like bone-specific alkaline phosphatase, unless the patient has liver disease. If he has a liver disease, don't use it. You have to go to bone-specific.
Would like to know from Dr. Amr, what's your opinion about this statement? Because this
coming.
is also my question.
Magdi Sharqawi is always ahead of time, so it's coming. Here, this is the next slide.
Okay, go ahead, Amr. Go ahead.
I don't know what can I do with you. Both of you are very smart guys. So here is a study that was published 2 years ago in JSON, and they did a small study in 43 CKD patients, 4 and 5, including dialysis. It's a cross-section study. And here is the bone-specific alkaline phosphatase. And here is the bone formation parameter by doing bone histomorphometry. So that's bone formation rate over bone surface. Okay, that's just how can we diagnose the bone formation. using the bone histology. And you see very, very good correlation if you use the bone-specific alkaline phosphatase. You see here, usually it's linear correlation. So it looks very good. The R is 0.6, so that's a very good correlation, and the B value is highly significant. Okay, here is using the total alkaline phosphatase, which is very cheap, available everywhere. It's a good test, and we should utilize it more. And I agree, it's a very good test. It doesn't give you the same correlation, so the R value is 0.5. But you still have some outliers here. So our patient, just try to be practical. Our patient has total alkaline phosphatase of 108, so around here. So the majority of these patients will have low turnover, low bone formation. But some of them, see this one, maybe it's outlier, with low level of total alkaline phosphatase around 100 or 110, but has very good, bone formation. Also, this guy has good bone formation. And on the other side, you might have very high alkaline phosphatase level with poor bone formation. But in general, it's good. If you cannot do the bone-specific alkaline phosphatase, you can use the total alkaline phosphatase. It's helpful, but it has less accuracy compared to the bone-specific alkaline phosphatase.
And also we have experience here, Dr. Amr, when we correlated alkaline phosphatase, total alkaline phosphatase with beta H, we find a good correlation and even predicts hyperparathyroidism in our case series.
Good. So alkaline phosphatase, total alkaline phosphatase can be used as a marker for bone formation, as long as the liver, as Dr. Magdi said, the liver function is good and the patient is not cirrhotic or has active chronic liver problem. It can be used, but compared to if we can do bone-specific alkaline phosphatase, it would be much more. Very good. So this patient here, we did bone-specific alkaline phosphatase, and we did the taritarate-resistant alkaline phosphatase as a TRAB5B. So, and here is the result. So the normal value for the bone-specific alkaline phosphatase is 6.5 to 20, and this patient has a value of 8. And the TRAB5B was 3, and the normal value is 1.7 to 5.9. So the bone, if we can take this as a biomarker of bone formation, the bone-specific alkaline phosphatase, it's a little bit on the lower side. And also the TRAB5B as a marker of bone resorption is on the lower side. So this patient might have low bone formation, low bone resorption. So this patient might have low or adynamic bone disease. And here, this is a study that was, this is the same studies that we discussed, the cross-section study that was published, very famous study published 2 years ago. And also the bone biomarkers and the high resolution bone image said it might replace bone biopsy, especially I know that bone biopsy is very limited if they do any in Egypt. So it's very helpful to use this bone biomarker if the bone biopsy is not available. If you want to get more information, you can do micro CTs, micro MRIs. You can do a PET scans that can give you more information about trabecular connectivity and more density than the BM. The last section here, I think within 10 minutes or so, I hate to be very detailed here and speak all the time. I'll just give you brief information. How can bone biopsy and bone histopathology help you in diagnosing the renal osteodystrophy? So there is different static and dynamic parameter to use, and the diagnosis of ROD was changed in 2009 when the KDIGO guideline changed the whole spectrum of ROD depending on the TMV classification, the turnover, mineralization, and volume. And every one of these parameters has some details how to calculate the bone turnover, the bone mineralization, and bone volume. But briefly, we have 4 kinds of renal osteodystrophy. We have osteomalacia, we have adynamic bone disease, we have hyperpara thyroid bone disease, and we have mixed uremic osteodystrophy. Okay, let's start by adynamic bone disease. Adynamic bone disease, the low turnover, the main problem will be in the low turnover. Then the hyperpara, these are the most common abnormality we are seeing, either adynamic or hyperparathyroidism. So hyperparathyroidism both have problem with high turnover, with low turnover and adynamic bone disease, high turnover and hyperparathyroid bone disease. Osteomalacia, we rarely see osteomalacia now in adults. Usually used to see this many years ago, especially in children with vitamin D resistant rickets or hypophosphatemic rickets. And the problem in osteomalacia is in mineralization. They usually have low turnover, so it's called low turnover osteomalacia. Then mixed uremic osteodystrophy, they have a combination of these things. Remember the bone volume, I didn't talk to at all about bone volume, but in all of these problems, bone volume can be low or normal. But in osteoporosis is a problem with the bone volume, the bone density, not with mineralization or turnover. Some of the osteoporotic patients might have high turnover, some have low turnover or normal, but the major problem is in the bone volume and bone density. I'm going to briefly discuss some bone histology and bone pathology here. I don't know if you are familiar with these pictures or not. So I don't know exactly where to start. Can anybody help me to identify which structure is this? Where is the cells? Where are the bone? Where is the matrix? Dr. Hussein, do you want to unmute anyone to help us?
If anyone wants to interact, please raise your hand.
And instead of Mamdouh,
Dr.
because
Magdi.
Mamdouh probably knows some of this.
Okay, I prefer to go ahead, Dr. Amr.
Okay. It's complicated, but renal osteodystrophy, we should at least know the basics of renal osteodystrophy. So there is, as we know, there is 2 components. There is the bone cells. We have to comment on the bone cells, which are 3 bone cells, mainly osteoblast, osteoclast, and osteocytes. And also there is the matrix, the bone matrix. The bone matrix, which is the collagen component of the bone. So let us start here. These cells are, you see the cursor, right? Do you see my cursor?
Yeah.
Very good. These cells are the osteoblast. Okay. This big multinucleated cell, this one,
osteoclast,
this one, are the osteoclast, right? So osteoclast, it comes from the monocyte macrophage. It's a multinucleated giant cell, and it's a big cell. It has 5 to 20 nuclei. So this one is very hungry. It eats the bone very quick. Okay. Osteoblasts are very slowly working cells and usually work together as groups. Osteocyte work by itself. It's a very active, biologically active bone cells. Osteoblast, they are very slowly acting cells. Osteoblast lives about 100 days. Osteoclast lives just 3 to 5 days. So the balance between osteoblast and osteoclast gives you the bone turnover. And this all happened because this magic cell here that lives in a lacuna, this is called an osteocyte. So osteocytes secretes different signals, both to osteoblasts and osteoclasts. If we need more bone formation, it will send signal for osteoblasts to increase bone formation rate. If we need more bone resorption, it will send the right signal to the osteoclast to increase the bone resorption. If there is a fracture or microfracture or old bone that need to be degraded and eaten, the osteoclast will be working very actively to remove this dead bone or old bone and to replace it with new bone by activating the osteoblast. So the interaction between these three kinds of cells that are orchestrated by the osteocyte is very important. So this is the cellular component, okay? Then you will see the bone. Okay, the blue part here is a calcified bone. The red part here is the uncalcified bone, which is the matrix or the osteoid, as Dr. Hussein said. So the osteoid it's a collagen type 1, it's a protein. So these osteoblasts, they lay out this protein. You know, when the chicken lay out egg, this osteoblasts, they lay out this protein. So first, this collagen is not calcified. Then the calcium, phosphorus, and the appetite, they comes and calcify this protein, and now it changed to this calcified bone. Here, the osteoblast, it changed because it gets entrapped inside the calcified bone, and now it changed its mature cell because osteoblast is kind of immature. It changed, transformed to a mature cell that get trapped inside calcified bone, and now it changed its name and structure to an osteocyte that start to secrete, elongation, and they communicate together and form network of cells and control the whole bone biology and physiology. So these are basically what we can check on our bone. So this patient is very typical for high turnover bone disease because you see the bone, the osteoblasts are very active here. They are forming, this osteoid, and this osteoid get calcified, and the bone is well formed and calcified here. But on the other side, you see very hungry, very prominent, multinucleated osteoclast that eats up the bone. So it starts to eat up the bone from here. And on the other side here is a bone marrow cells. And there is advanced fibrosis. You remember we used to call this hyperparathyroid bone disease. We used to call it osteitis fibrosis. Because it looks like an inflammation. All cells are hyperactive, right? When this is exactly what you see if there is an abscess or inflammation in any organ. You see osteitis, so it's inflammation of the bone cells, and this is the reason that this patient might have severe bone pains because the bone is very active and it looks like inflamed. But also fibrosis is called osteitis fibrosa, and if you see it in the X-ray, they call it osteitis fibrosa cystica. You see the cysts because the bone is replaced by fibrosis, and instead of being very strong structure, it changes to a fibrous tissue, not a bone tissue. This is a typical, hyperparathyroid or high turnover bone disease. Then we do something called double labeling. Before we do the bone biopsy, we give two kinds of the tetracycline and the microcycline. We call it 2-10-4. Then we do the biopsy. We give 2 days of the microcycline, then 10 days off. So the first is the first label for 2 days. Then you give 10 days off, then 4 days of tetra. Then we do the bone biopsy, and this gives us this double labeling. Here there is no double labeling. Here, the tetracycline loves to go to the bone. It lives inside the bone and for long time. So in this hyperparathyroid patient with high turnover bone disease, all bone are labeled. You cannot even see the double labeling because hyperactivity of this bone. Okay.
Is there a ratio between osteoclast and osteoclast, Dr. Amr?
Usually, the osteoblast to osteoclast is usually about 1:50 to 1:100. Usually, the osteoblasts are very, very prominent compared to the osteoclast. You remember the bone loss or bone degradation that can happen only with one osteoclast. In couple days, it takes 100 days for osteoblast to rebuild. So usually the destructive power of osteoclast is much higher than the constructive power of the osteoblast. So usually osteoblast is much more prevalent than osteoclast. Okay, here is another example, another spectrum of the bone disease. Here you see, do you see here any cells? There is no cells, it's acellular, right? And on the other hand, you see the osteoid. The unmineralized bone is very thick. The osteoid volume is very thick and it's hypocellular. This is an example of low turnover bone disease. This is an example of mixed renal osteodystrophy, because at one side, you see the osteoclast here. They are not big and not like, you know, with 20 multinucleated cells like the other one we saw at the beginning. And you see also here the osteoid and the mineralized bone. But on the other hand, the other side of the slide, you see the osteoid thickness is very high, the osteoid volume is high, and the bone cells is very less active. So it's mixed renal osteodystrophy. It's not only this, it doesn't give you only an impression about the bone cells, but also we can do stains for the aluminum. So here you see the aluminum staining with red that stained all the bone borders. So this vision, we don't usually see this anymore. This is an older slide, but I don't know if you do it in Egypt, you might see some alum toxicity or not, I don't know. There was some studies was done in Saudi Arabia many years ago, and they said aluminum toxicity was about 20% of their patients. But this article was very old, I think 25 to 30 years old. So I don't know the status now of our patient in the Middle East in general. This is a very, very interesting patient who has very severe bone pain, and we biopsied him many, many years ago, and we find this oxalate crystals. Typical, you see this crystals in the kidney as well, right? And in the bone marrow. So it's this is a problem with this patient. Just this oxalate crystal is projecting to the periosteum and causing this severe pain. This patient, unfortunately, he committed suicide because of this pain many years ago. Okay, let us summarize here what we have found in our patient. This lady, very nice lady on dialysis who had a traumatic fracture and had normal BMD by DEXA scan, abnormal TBS as a trabecular bone score by using the same DEXA machine. So we thought she might have problem in quality rather than quantity. We did bone-specific alkaline phosphatase and TRAB5B, both were on the lower side. We did bone biopsy, and as you can see here, the bone biopsy is very acellular, so there is no cells. Here is adipocytes, by the way. They call it there is a trade between osteocytes and osteoblasts and adipocytes. So you don't see bone cells, and instead you see this adipocytes, which is fat, cells in the bone, replacing the bone itself. Then we are more certain, I think everybody now is convinced this patient has low, turnover bone disease. We have more evidence, not only based on one element, but we have different elements. We have lab, we have X-rays, then we have bone pathology, and I think we are very certain that this patient has low bone turnover osteoporosis, how we treat this low bone turnover osteoporosis, and how can we use this diagnostics to have our plan to treat our patient and to classify our renal osteodystrophy patient and to treat them. I think this might be another topic in the future we can discuss.
Okay, thank you very much, Professor Amr, for this exciting, stimulative, and actually, there are many lessons you raised today. What I have a question. What about the rate of bone biopsy in your center? I know that you do bone biopsy like what we do renal biopsy here. Am I right?
Yeah, you're always right. So the thing is, we are biased here because we have one of the biggest histomorphometry labs in America even. So we get bone biopsy from everywhere in the States. So we do also bone biopsy not only for renal osteodystrophy patient, but also for patient with osteoporosis, with normal kidney function, and other reasons as well. Because we have a big metabolic bone disease lab, not only to the kidney, but also to other metabolic problems, including even genetic disorder with osteogenesis imperfecta and other bone-specific disorders.
And what are the typical indications to do bone biopsy in CKD and hemodialysis?
Very, very good question. As I will stick to the KDIGO guidelines when they said if this will impact your treatment decision. So if you like this case, which is very typical, by the way, very typical case. So there is two spectrum. If you have very high, PTH, like PTH of say 1,000 IPTH, more than 95, 96, 97%, this patient will have high turnover bone disease, right? Very, very small chance, less than 1%, that this patient with a PTH of over 1,000 will have low turnover bone disease.
True.
So this patient, I wouldn't, if the PTH is very high, I will treat him as high turnover bone disease, okay? On the other spectrum, if the PTH is 2-digit, 40, 50, 60, 100, less than 150, this is also, very good correlation between low BTH and adynamic bone disease or low turnover bone disease, right? So this is the other spectrum. So I don't usually biopsy either both of these spectrum, very low BTH or very high BTH. But the problem is most of our patients are actually in the middle. So if you have a BTH of 150 to 600, as recommended by the KDIGO guidelines, 2 to 9 folds of the normal, right? Which is about 150 to 600 or so, depending on your lab. There is no way, depending on whatever is available in our labs, except maybe using the total alkaline phosphatase can give you some help, maybe using the DEXA scan to see if this patient have osteoporosis or not. But if we can use other biomarkers of bone formation and bone resources, it might help. And if you can use, the high resolution technique like the HBRQCT or the micro CTs or beta scans, this would help also to give you some, diagnosis and assessment of bone quality. If you add the TPS on the BMD in the DEXA scan, this will help. But sometimes, there is a big, chance that you can misdiagnose your patient, especially now, depending on the KDIGO 2017 recommendation that we can use anti-resorptive therapies, bisphosphonates, and denosumab and others for this patient. So if you want to use that, you have to make sure that you are treating the right pathology.
Okay, Professor Said Khamis wants to interact. Dr. Said.
Hello, Dr. Amr. How are you, sir?
I'm very good. How are you, sir? I'm very missing you.
Me too. I hope you stay safe, inshallah. Regarding I would like to ask two questions, but what Dr. Hussein asked the first question. Second question is, if we wanted to add complexity to already perplexing issue, if I have a patient with end-stage renal disease on hemodialysis and they develop mild hyperbara and mild hypercalcemia, and in the meantime, the other bone parameters, I mean lab parameters, are not conclusive, how can you rule out or in primary hyperparathyroidism in such patient? Thank you, sir.
Okay, so primary hyperbara, usually the BTH doesn't go up to more than 300, 400, or 500. If you have a BTH of more than 400, 500, it's usually secondary, not primary. The problem is usually hypercalcemia in this patient is iatrogenic. So it's either because of high calcium dialysate or calcium-containing phosphate binders or calcitriol and other vitamin D analogs is the reason for this hypercalcemia. If you rule out all of this reason for an immobilization, of course, if the patient doesn't immobilize, if you rule out all other reasons for hypercalcemia, I do a systematic scan to make sure that this patient doesn't have primary, and this primary was misdiagnosed as secondary for a long time, and this patient has nodule. But sometimes it's very hard to distinguish if the patient, especially on dialysis for a long time, even if we misdiagnose primary hyperbara at the beginning, it might be now because of the long-standing secondary hyperbaras. It might be a nodule, not because of the primary, but because of the tertiary hyperbara. But by the end of the day, if you either have a nodule because of primary or tertiary hyperbara and the VTH is very high, I think we would go ahead and treat this either with resection of this nodule, or we can try calcium mimetics that can control hypercalcemia and can control also with less chance the severe degree of secondary with that change it to tertiary hyperbara or possibility of primary hyperbara. So by the end of the day, I think either if it is primary or tertiary, the patient will be aggressively treated with cinacalcet or parathyroidectomy.
Thank you, sir.
دكتور طارق طنطاوي. دكتور طارق. دكتور طارق.
السلام عليكم. السلام
وعليكم
عليكم.
وعليكم السلام ورحمة الله.
Really enjoyed تماما دكتور عمرو بال nice lectures. But I would like to ask you, is it a virtual case or is it a real case?
This case?
Yes.
That's combined because this is a very common. I have personally, I faced this problem many times. So this is the reason that I give her a name of Susan or something. Yeah. But I see this is my, I would say, our approach for this common problems that we are facing all the time. She might be, the Susan name or, different name, Fathaya or whatever. But I think everywhere, every time we see this problem.
Because from the start, I feel we are overwhelmed here by drugs like calcium and vitamin D. And in spite she had hypercalcemia, low PTH. So for what purposes? From the start, I diagnosed clinically. We haven't facilities for biomarkers, no renal biopsy, but we usually handle with our cases clinically. Yes. This case, from the start, I have to omit a withhold or withdraw calcium, vitamin D, and I follow the result.
I completely agree with you, and this is what even in America, regular nephrologists do most of the time, but you still can miss this patient. Of course. If we just stop, if we did DEXA scan and DEXA scan is normal, and other parameter looks okay, VTH is not terrible, patient has mild hypercalcemia, and over the time, this hypercalcemia is gone, we put her on low calcium dialysate and gone. So we wouldn't do anything further, right? We wouldn't treat her low or adynamic bone disease by giving her, for example, Forteo, PTH, right?
Yeah. Yeah.
So you wouldn't, do much, but you can just decrease the vitamin D receptor analogs. You can, of course, don't give her cinacalcet. You can decrease calcium in dialysate, calcium intake as a phosphate binder. Most of us, they do, 90% of us will do this.
Yeah.
But if this
Yeah.
is enough or not, this is a question. And
Yeah.
to go 1 mile or 100 miles further, to be certain that this patient has a certain kind of pathology, and depending on this, you treat her appropriately, I think you need to do more tests.
Yes, of course.
The last question from Dr. Mustafa عبد الخالق.
السلام عليكم دكتور حسين، ازي
وعليكم
حضرتك يا
السلام.
فندم؟
اتفضل يا باشا، اتفضل.
مصطفى عبد
دكتور
السلام معاك
مصطفى.
دكتور
مصطفى
حسين.
عبد السلام،
ازيك
اصل
يا فندم؟
مكتوبه مصطفى عبد الخالق. اوكي، جو
هنا
اهيد
العاده بقى معلم.
دكتور
ماشي يا فندم.
مصطفى.
دكتور حسين، دكتور عمرو، ازي حضرتك يا فندم؟ بقول لحضرتك
ازيك يا مصطفى.
ازيك يا
انا قلت
فندم؟
مصطفى عبد الخالق بتاع
العظم.
الاورثوبيديك.
انا من ساعتها خايف برضه.
لا يا فندم.
اتفضل يا
بقول
دكتور
لحضرتك
مصطفى.
يعني if we depend on the clinical aspect as you know، يعني الاكتيفيتي، البون اكتيفيتي والبون تيرن اوفر باي ماركر والبون بايوبسي از نوت افيلابل، واعتمدت على الكلينيكال. when reach check the patient امتى واعرف ان انا في الرونج واي وفي الرايت واي؟ يعني المفروض ان انا اعمل ري ايفالويشن قد ايه للبيشنت لو انا هعتمد على الكلينيكال سنس هنا والحاجات المتاحه عندي سواء في مصر او في غيرها.
ممتاز. First of all, I will quote this statement. The best way is to predict future is to make it. Okay? So the best way to predict the future is to make it. If we don't do anything and we just say, okay, this is not available, we are dealing whatever we have right now, we are not going to move forward. We need to be more proactive rather than reactive. As a nephrologist, and I'm very happy with the level of education and the training in Egypt for nephrologists. Yeah, this was guided by Dr. Hussein and other great professor, Dr. Magdi and others. This is really, very, very good achievement when it comes to the educational activities. But as you see here in this slide, knowledge is of no value unless you put it in a practice. We have to apply these things. We have to start to not only scratch the surface, but also to, dig deeper and deeper and try to find answer to whatever we have, questions for our patients that we see on every day. If we just do the basics and the very little things, we are not going to move forward. We need to do more and more. And it's not only first, if it's knowledge. First, you gain the knowledge, then you change it to your daily practice. If you have, say, I don't know, your most common lab in Egypt right now, whatever the name is. If one doctor send, bone-specific alkaline phosphatase, they said, no, it's not available. If another doctor send it in the second day or whatever, they will say, oh, it's not available. Then this will ring something in their ears. Okay, this test is going, it's more, needed right now. So why not to buy the test? So why? I mean, it's simple things we can order because as we, saw that the total alkaline phosphatase is not enough, the BTH is not enough. So why not to order, more, especially if you have a younger patient who are productive and, we can afford a better care of her. Why not to do that? It's just, a biomarker, non-invasive test, and it shouldn't be very expensive and can give us some information. Using TBS, trabecular bone scores, it's not going to cost any more, dollars or guineas or whatever. It's the same technique. Just when you get a DEXA scan report from the technician or from the radiologist, ask him, first of all, don't look only to the BMD, but also look to the TBS. If they don't give you this information, tell the radiologist, I hear this thing about the TBS and gives you more information about the bone quality. Why not to do it? It's just a software you add it to your machine. It doesn't cost you, the radiologist, too much, and it doesn't add any radiological exposure or length of time or anything for the patient. So I think just with simple thing, I don't think that we need to biopsy every patient, or you don't do here even in our program, we don't do a lot of biopsy for end-stage kidney disease patient, but at least we can do other non-invasive tests and get some information about what's going on in their bone and their type of renal osteodystrophy.
Okay, but I think we exhaust you, Dr. Amr, today, 2 hours and 10 minutes. So it is quite exhaustive, but we have a lot.
This is the only thing I disagree with you. I'm not. I love this. It's a teaching experience, not only to you guys, but also to me. I think the most benefit comes into the person who presents, because he reads, he prepares himself, and I really learn from your questions as well. So I'm happy, and as you know, usually I'm very happy when I see you guys all and interact with you. I was supposed to be in Mansoura nephrology meeting this week, actually, and also Cairo meeting, nephrology meeting this week. So, week to back. But because of the COVID-19 thing, I wasn't able to come. So I think it was very good opportunity. My brother Hussein gave it to me today to interact with you guys.
It is extremely pleasure, Amr, to have you with us today. You enriched our mind regarding the bone, and you dig the concept of bone quality rather than quantity. We thank you very much for this concept. And as you mentioned, we worked on not only on knowledge, but we are believers in eyes don't see what the mind doesn't know. So we start by this, and even in transplantation, we have a lot of laboratory markers and the issues added when we know. So we start with knowledge, and then we try hardly to improve ourselves. And from the quality point of view, even if we cannot make everything available, we just change. We should make some change toward the better side. I wanted to have from you a promise to meet again and again, because you have a wealth of experience and knowledge, and all of us get the benefit from your talk and your discussions. Thank you very much. No words. I can find no words to express my gratitude for your presence with us this night. Thank you very much.
Thank you, sir.
And goodbye for all, and hope to meet again and again. Thank you. Thank you, Amr.
Thanks.